Tola, what's up, man? Welcome to the Psych Guys podcast.
It's great to be here, man. We've talked about this for a really long time. I'm happy to be here.
Right. So me and Tola met in good old San Francisco through the American Psychiatric Association. I believe you just graduated from the Leadership Fellowship, right?
The Diversity Leadership
Oh,
Fellowship,
okay,
yeah.
cool. Yeah, so I was in like a different fellowship as part of the APA, but we met in San Francisco. We kind of hit it off. You actually graduated from a residency not all that far from me and Joon, Atlantic Care, right down by Atlantic City.
No,
Wait, I got that wrong.
Yes.
Oh, I
So
thought you were at Atlantic
I
Care. Oh,
was
okay,
part of the Hackensack Meridian system. I was at
Oh,
Ocean Medical
Hackensack.
Center. Yeah,
okay.
but I mean, like, there's a couple of big names in psychiatry in Jersey. It's easy to like interchange one for the other,
Right,
and we're all
right.
friends, so it truly doesn't matter.
It is a small world. Yeah, like I remember when me and you first started chatting, you were like, "Oh yeah, dude, I know your old chief, Uche." So it's just kind of like the world of psychiatry. There's not that many of us, and now I know you're a forensic fellow down at Emory University. I did get that one right?
Yes.
Okay. Okay.
Yeah.
So before I don't want to try to butcher your name, so can you please? What is your full name for the audience?
So my full name is Omotola Ajibade, and no one ever gets it right, and it's all right. But the name is from southwestern Nigeria. I'm Yoruba, so I'm very proud of my roots.
Yeah, cool. So, I'm really excited to have you on tonight. I'm sure this is going to be a great episode, and I hope you decide to come on in the future. So, for the listeners, what we're going to talk about is you did this really cool presentation at the APA that, unfortunately, I wasn't able to be present at, but it was about like sequential intercept mapping. I know you incorporated like The Wire, the HBO show, and we can kind of get into that. I want to talk about your interest in forensics, just like overall your experience being now an attending psychiatrist who's doing a fellowship, your particular interest in photography. I don't know, anything else, Joon, that you want to touch on this episode?
I think you covered everything, Logan. But before we start to dive into the nitty gritty details, so Tola, there's a lot of people that tune into this show that aren't necessarily psychiatrists or even involved in the mental health field. So I know we threw out the term a few times now, forensic psychiatry. You are currently a forensic psychiatrist fellow. Can you quickly explain to the audience, just real generally, like what exactly is forensic psychiatry and how does it differ from general psychiatry?
Okay, so no one ever knows what we do, but I guarantee if you pay attention to pop culture, you've definitely seen a forensic psychiatrist or two. The most famous forensic psychiatrist, probably in all of pop culture, is maybe Hannibal Lecter, um, which, like it shocked me when I found that out. But essentially, forensic psychiatry deals with the intersection of mental health and the law, and that can take any number of forms, but especially when you're in training, you do a lot of criminal work, so you are assessing people's competency to stand trial, because we believe generally that it's a moral obligation that if you're going to accuse someone of a crime, that they should be able to mount a credible defense for themselves, and where that comes and where there are questions about the person's ability to do so, you call a forensic psychiatrist to do those kinds of assessments. On the civil side, it can range from any number of things, from like if you're putting together a will and everybody is familiar with that line, so I so and so being of sound mind and body, if that ever gets called into question, that sound mind portion, you could call in a forensic psychiatrist to do that kind of assessment as well. So it really runs the gamut. If you can attach a legal question to a mental health issue, you can call in a forensic psychiatrist.
It's got to be a pretty challenging field. I mean, I imagine, forensic psychiatry is the intersection of mental health and the judicial system. So I'm going to assume that you are dealing with people that are within our criminal justice systems
Absolutely.
pretty often. And we all know that that's an area that's greatly underserved. So first and foremost, thank you so much for taking the burden and contributing to our society in trying to better the mental health of those that are most in need. So we
Yeah.
really appreciate you for that. And
Thank you.
Tola, I'm really curious. Given that it seems like such a challenging field to be in, what motivated you? What gave you the passion to undertake an additional year of training to be able to serve that population to the best of your abilities?
So it's a it's quite dramatic, really. I never, like, when I was a med student and when I had high hopes of becoming a doctor as a kid, I never imagined that I would go into forensics. But when I was in med school, I had this really jarring experience. As you can imagine, my last name is probably not that common in the U.S. And so for most of my life growing up, I assumed that everybody with my last name was a relative of mine, or at least a close family friend, you know. And then the in med school, there was a kid in Georgia with my last name who died in police custody, and it was a pretty brutal experience. And for about a year and a half after that, um, I would go places and watch people physically burst into tears because they thought that I was the one who had died. And so, like, I remember going into my doctor's office one day, and the nurse started crying and saying and thanking God that I was still alive. Um, and I didn't, like, that was an unsettling experience. I didn't really think much of it until, like, the George Floyd protests started happening, and then you start to think about your role as a black man in medicine, which is an institution that has routinely harmed black people. And, like, what the kid's name was Matthew Ajibade. What Matthew needed all those years ago was a psychiatrist because he was suffering from a mental health episode at the time that he was arrested. What he needed was a psychiatrist, and I was the guy that some people had mourned in his stead, and I now happen to be in that position, and that really forced me to focus down and really dive into the world of forensics.
Wow, that's an incredible story. Um, you mentioned that medicine has been an institution that has traditionally been harmful or hurtful to Black Americans. I would love to hear a little bit more about that. Can you educate me a little bit?
So, like, psychiatry has, like, I always tell people, psychiatry uh, lives based on the way we structure our society. So a prime example of that is that once upon a time there was a disease called drapetomania. And drapetomania literally means, like, runaway slave sickness. So it was a disease coined by this guy named Samuel Cartwright, and essentially, you can imagine what that does to a person when you tell them that the desire to escape your own humiliation, dehumanization, subjugation, um, and just straight up deprivation is a mental disorder. What does that do to generations of people, right? How does that then get turned into an institution over multiple generations? And some drapetomania no longer exists in the DSM, but there are diagnoses in the DSM that still have racist outcomes. So, like, there are issues surrounding, like, protest psychosis, or the inordinate, like, schizophrenia is more likely to be diagnosed among black people for various reasons. Oppositional defiant disorder is more likely to be tagged onto black children for various reasons. Conduct disorders for the same reason. And all of these things have stigmatizing implications. And so, when we think about our roles in society, especially in this day and age where we're trying to be more sensitive to to issues that involve race and culture, because fundamentally, as psychiatrists, we have to take someone's context into account when we're trying to be more sensitive about these issues. It really helps to know where we've been so that we don't repeat the mistakes of the past.
Yeah, that. What a powerful kind of response. And what I think a lot about in psychiatry. If the listeners don't know this, so I'm this white guy, right? And I feel sometimes I feel limited in my own abilities to help out other patient populations that look different than me. Sometimes I perceive as though the patients are like, well, okay, well, what does this white guy know about my experience as a minority? How is this white doctor really going to be able to help me with what I'm going through, and some of the issues that you're touching on, upon that discrimination, how psychiatry as a whole has treated different ethnic groups differently, unfortunately, even though it's whatever. I guess what I'm trying to get at here is sometimes I face these difficult situations where I do, like you highlighted, there's different rates, unfortunately, of the diagnosis of oppositional defiant disorder in Black men. But what I think a lot about sometimes as the world of psychiatrists, like, we are sometimes limited because this world is so much more diverse, and what impacts those kind of diagnoses is more than just the psychiatrist too. What I'm referring to is, like, the neighborhoods these individuals grow up in, the lack of maybe meaningful economic opportunity, the lack of safe housing that sometimes these groups unfortunately are exposed to. So that's why I'd really admire individuals like you who go into forensics. That right there is bridging a line between psychiatry and law. But how do we go even further? How do we go into the world of politics, maybe into the world of economics, to continue to create bridges between all these aspects of society to better serve lower socioeconomic groups, right? Or socioeconomic groups that are disadvantaged in our society.
So when, like, in the rare instances that I'm called upon to teach, I tell med students and younger residents, people exist within a system, they act within a system, and that system acts upon them. And really, it should be systems, because all of these things are interlocking. And to the point of why we all gathered today to talk about, like, sequential intercept mapping, that's really the goal of something like this, is to look at how people with mental health and also substance use issues move through the legal system at various points in the chain. And the goal is to figure out where you might be able to help somebody address their core issues in order to reduce their rates of having episodes and potentially reduce their rates of getting involved or re-involved in the criminal justice system. But, like, America is a carceral state. And so what that means is that we have both the largest absolute numbers of people who are incarcerated. And I think as a proportion of our population, we also have the largest numbers of people who are incarcerated. And there is a not insignificant portion of them. I don't have the exact number off the top of my head, but there's a pretty decent chunk of those people who are incarcerated for mental health and substance use related reasons. There's multiple states where the prison or the jail is the de facto mental health care provider. I know that's certainly true in California. I've seen videos of Gavin Newsom saying that, and I imagine it's true in many other states across the country as well. Um, and so that's really what things like sequential intercept mapping aim to do, is to help show us the lay of the land, and then we can start to figure out where the holes are and develop tools and policies and resources that can help to plug some of those holes.
Can you explain exactly what sequential intercept mapping is?
Okay, so it's a model that came out in the early 2000s. A bunch of people, much smarter than myself, came up with it. But it really looks at the continuum from point zero, which is when you're in the community with no involvement with the legal system at all the way to point five. So 6 points in the chain where somebody gets moved along the legal process. So and each point in the chain is called an intercept. And you can start to think about what you would do at various intercepts to sort of help that person move out of that cycle of being involved in the legal system and potentially move into a space where they could be living their best life. And so, Intercept Zero, you're just in the community, you're living your life. You may or may not have an episode. Somebody calls crisis line, and they get you the resources that you need. Um, Intercept One is where like law enforcement gets involved. They call the cops, call 911, all of this, all of those kinds of things. Intercept Two, you're in your initial detention, so like you've been booked, you're in jail awaiting trial or something, or you've gone to your first court appearance. Intercept Three, you start to think about whether or not this person actually serves time, um, or gets transitioned into some kind of dispositional or specialty court, like a mental health court, a drug court, or something like that. Intercept Four, that's like this is for people who have um, gone through the carceral system. So they've been in prison a while, or in jail for a while, and you're starting to think about what reentry might look like for these individuals. And then Intercept Five, the last step in the chain, is the return to community. So if they've served their time and they're not on probation, great. If they are on probation or parole, what does that look like for them? And at each point in the chain, you start to design, you start to figure out what resources are available and where to plug those holes. The big step in all of this is putting together a mapping exercise. And so you have to call in a lot of stakeholders within your respective communities to really go through and figure out what's what. And that can be quite the undertaking.
Yeah, it sure does
Right.
sound like it. And maybe you might not have a great answer to this because it's a really hard question. But Tola, I'm wondering, in your opinion, where do we go wrong? At what point did we get things so wrong that our jail systems are serving as a de facto mental health hospital?
So there's a number of complicated answers that have to do with both policy and politics. Um, the short version is that, and also like medical advancements. So if you look at the history of psychiatry, Thorazine was really the first antipsychotic that came on the market, and Thorazine changed the game. Suddenly, people who had been institutionalized for years, even decades on end, were calm and stable enough on Thorazine that they could basically be let back and reintegrated into society. And that started the arms race that has evolved into our modern landscape with various antipsychotics today. Now, at the same time that Thorazine came out, the Community Mental Health Act also was passed by Congress. That was probably the last big legislative win that Kennedy had before he got murdered. But what that the goal of the Community Mental Health Act was to deinstitutionalize a lot of our state psychiatric hospitals, to move people out of those places because they really honestly weren't getting care, and were getting they were essentially being warehoused out of sight, out of mind. So he wanted to move those people out of those hospitals and back into the community, and really have local jurisdictions fund a variety of community mental health resources specific to their needs and their populations. But the funding was never properly appropriated, and it's sort of like you have a hard time, um, holding people accountable for instituting a policy the way it was intended when you're not alive to do that. And so while the CMHA was very well intentioned, it also created a lot of problems down the line. And so when communities didn't have the appropriate resources, people started getting warehoused into jails, and then jails became the new psych hospitals.
So is this one of those things that started out with good intentions? In this case, being, I mean, you don't want any individual to have to be committed to a hospital for a vast majority of their lives. And from what I understand, it really started, I believe it was around World War II or maybe World War I, where people started to walk into these psychiatric institutions where at the time there were some pretty inhumane and grotesque procedures going on. And they started taking photographs, and these photographs were sent out to the public, and that's what really, from my understanding, is that's what really catapulted this vision that we need to reimagine our mental health systems. And I believe it continued under President Reagan, but what essentially happened was that because there was such an emphasis on getting people out of these psych hospitals, a lot of the beds ended up closing down, and we're in a situation today. And maybe this has to do with some of the lack of resources that you mentioned and alluded to earlier. But from our end, from the end of a psychiatric resident right now who's staffing our local EDs, sending people to these inpatient facilities, we do really have this big issue of lack of beds. People end up staying in the ED for days and days and days, sometimes weeks, and it's really difficult to see. So I can kind of see how that would lead to, this unfortunate reality that we have, where a lot of the mental health issues are unfortunately just labeled as maybe criminal behavior and diverted to our criminal justice systems instead. So what are your thoughts on that?
I completely agree. Like it's been a mess and a half. Let's put it that way. The fact is, we end up using law enforcement as like the de facto tool that um, for anything that society just doesn't want to deal with, and that includes mental health crises. Um, the like on some level, like all of this stuff was well intentioned. I don't think anybody was deliberately trying to be an asshole and saying, hey, let's make the lives of people with mental health issues or substance use issues absolutely atrocious. Okay, actually I take that back. Maybe Reagan was, because the whole war on drugs was a whole like there was Nixon and then Reagan, and that's too many policy stuff. But yeah, the like fundamentally, on some level, we did not see substance use in particular for the biological disease that it actually is, because some people are genetically predisposed to various types of addictions. And we did not adequately consider some of the environmental factors that would make some of those things more likely. Um, and on the flip side of that, there's also like in terms of the shutting down of beds and everything, some of those hospitals were just horrible. If you ever get a chance to read like U.S. case law, there's a case called Wyatt v. Stickney, where this kid in Alabama, honestly, like I think he, like based on what I know of the case, it seems like he might have had what we would think of as ADHD, and his aunt put him in a psych hospital in where she worked. And the kid ended up hating it and talked about how horrible the conditions were, just like those photographs and stuff that you were mentioning earlier. The hospital had been underfunded for years, and so the superintendent of the hospital, Dr. Stickney, actually encouraged him to sue the hospital because he was hoping that the lawsuit would force the state to give the hospital more money to appropriately staff the units. And there was a whole lot that came out of that one case and several sister cases in the deinstitutionalization generation. Um, the like the problem was, and till this day, most of the criteria that was laid out, I think they're called like burn bomb criteria. Most of the criteria that was laid out in terms of appropriate staffing and patient ratios and so many other regulatory things related to clinical care haven't been perfectly followed. And so it's really a tough problem overall, but everybody just has to do what they can for as long as they can with whatever resources they have available to them.
Right, right. And so I know for this presentation that you gave at the APA National Conference where you talked about this sequential intercept model, I know that you brought up the HBO's The Wire. And you sent that to me in June. We watched that clip. And I'll let you kind of describe it better. But in this clip, setting this up, if you haven't seen The Wire, I greatly encourage you to check it out. But it's basically the Baltimore police force meeting with. I guess I actually don't know if it's a bunch of different gangs or one criminal organization, but setting up this, was it Nor Amsterdam, or what did they call it? It was basically like they allowed this drug marketplace to occur within their cities to try to contain it. I'm curious, like, why did you bring that into your presentation?
So the idea, like, my buddy Marcus Hughes, who gave the presentation with me, and I, we're both photographers, and we love using media for storytelling. And at my very first APA, as part of the fellowship program that we talked about earlier, I had started hearing about sequential intercept mapping, and I thought it was such a cool idea. And so we were looking for a way to really use media to illustrate a critical point. And in the brainstorming process, we came up with the idea to really imagine the Amsterdam program that was done in season 3 of The Wire as a sort of sequential intercept. Um, and when you really go through that story arc, Bunny Colvin, who ran the department, called up all of the local gangs and said, essentially, we will give you 3 spots in the city of Baltimore. You can do whatever you want, so long as there is no violence. If there is violence, we will rain hell on you. And so in so doing, they were able to eventually get, like, needle exchange programs going, crime in the city reduced dramatically, and all this other stuff. But unfortunately, the program was short-lived in the story arc of the show. Now, when I was giving the presentation at APA, one of the people in the audience is actually from Baltimore, and he pointed out that there's a scene in the clip where the mayor is meeting with a bunch of intellectuals talking about the public health impact of what the Amsterdam program was doing, and allowing people to be able to create needle exchanges and to be able to do HIV testing and all these other, like, really great public health measures. One of the people that's in that scene was one of the former mayors of Baltimore, who was instrumental in setting up one of the first needle exchanges in the U.S. Period. Um, and so that was a very fascinating tidbit. But yeah, I encourage everybody to watch The Wire. It's a um, brilliant depiction of what the war on drugs is like from a law enforcement standpoint. But along the way, you also get these interesting ways of imagining what drug policy looked like, what could have been done well, what should have been done better. And so, in our presentation, we used that story arc to illustrate what sequential intercept mapping could look like, and sort of talk about what was right about what Bunny Colvin did and what could have been done better.
Right, right. And I like to kind of play this game on the podcast, like imagine if you were the governor of Georgia. Imagine if you were, the head of mental health in America or something. Like, what would you do? What would be the policy that you would want to try to implement? Me and June, in episode 20 of this podcast, we did this examination of needle exchange programs, supervised injection sites, and medication assisted treatment, and we were mostly looking at San Francisco. And I don't remember the exact stats offhand, June, maybe you do, but long story short is that in my opinion, these needle exchange programs sounded really good in theory, and then in real world practice, they weren't as effective. That ensured that, yes, these individuals were getting clean needles, which, yes, is a harm reduction, yes, reduced chance of infection, transmission of HIV. I get all of that, but actually getting people into treatment and reducing their use or having it be at a more sustainable, useful level wasn't something that necessarily was achieved, in my opinion. I'm very curious, what is your opinion on needle exchange programs, like harm reduction models? Like, what do you think about all this?
I think, like I said before, everything exists in a system. The system acts upon you, and you act within the system. Like it's a give and take. So a needle exchange program is really only one tool in the arsenal. It has to be coupled with things like safe use sites and on demand like drug testing. Because one of the issues that you run into is that people don't always know what they're taking, and so that becomes a problem for their health outcomes, because you could take something that would make you overdose, you could take something that you're allergic to, you could take something that's poison, you could take too much or too little, or however many different ways that could go. So that's one side of things. The other side is that there's no like inherent to the risk of taking a lot of these drugs is the risk of overdose and of withdrawal. And depending on what substance you're using, both either the overdose or the withdrawal or both could lead to detrimental harms. Someone who dies from an overdose or someone who dies in withdrawal is someone who doesn't get the opportunity to um, receive further treatment or to live a meaningful life. So even in that regard, it's still a tragedy all around. So in as much as the current utility of needle exchanges may be limited by your assessment, and I certainly take that criticism pretty well, I still think that it's only one tool right? And you need multiple things to work together. You're like, a hammer alone isn't going to build a table. You need a couple of saws, a couple of screws, a couple of nails, a couple of like a whole like all you need all sorts of things to actually get to a finished product and to fully improve outcomes. And I think we're all in agreement that we just don't have that quite yet.
Right, right. June, I'm very curious. What are we did that episode, episode 20. We're retouching on it now. That's roughly what, 5 months, 4 months after that initial conversation.
Right, right,
How's your attitude changed and evolved?
right. Well, I'm going to be honest, I don't think my attitude has changed at all. I mean, we haven't really thought about it in an academic sense until probably right now that we're having this very challenging conversation. Tola, just to kind of fill you in. So, in that episode, we kind of reviewed the supervised injection sites, needle exchange programs, and I had kind of a very skeptical attitude towards it. Coming in before I did that podcast episode, I felt like these were great programs. These were things that were going to help people. But after doing some more research, I left feeling a little bit more uneasy and a little bit more skeptical about the efficacy and the ultimate goal of these programs. So the first thing that I'm very curious about is, because I know you mentioned that we don't have all the tools right now, and you did mention like supervised injections. So the main questions that I have for you is what is the ultimate goal of harm reduction and supervised injection sites? Are we aiming to allow individuals to use drugs and keep them safe while they're doing it? So in a sense, we're letting them get high, but allowing them to do it in a safe way. Or is the ultimate goal to rehabilitate that individual and hopefully get them to a place where they're no longer dependent on substances, where they're able to regain control of their lives and have more of a resemblance of what we consider to be a quote unquote normal life, right?
Yeah, I think that's on the individual to decide. Like, when you're in the throes of an addiction, you don't really like certain decisions may be beyond you at that point. But if you're able to help them regulate, because one of the like neurobiological problems with addiction is that your homeostasis, for lack of a better term, like your body's ability to regulate itself, has been thrown off balance pretty dramatically. And so initially when you start developing a habit, you're chasing the high, you're chasing the feeling of using the drug. But over time, you start to use in order to prevent the side effects, right? And so initially, I think the primary goal should first and foremost be that step one that you described, where we're giving people a safe way and a regulated way to be able to use whatever drugs they're already on, because that alone will create a measure of stability in their lives that would allow them to function. And then if they do that for long enough, in theory, some of them might decide that they want to come off the drugs, and then we could start to have conversations about medication assisted therapy, either in an inpatient setting or in an outpatient setting, or however those things are going to interlock. But in order for them to get to a point they may want to consider um, reducing their use or even potentially eliminating their use, they have to first regulate their use and then start to build a meaningful life and connections beyond their addictions. It's sort of like Maslow's hierarchy of needs, right? So before you get to a point of like self-actualization and thinking about these higher order things, you have to have your basic needs met. And in the throes of an addiction illness, your basic needs are to either to prevent the side effects of the addiction first and foremost, and then build things from there.
What would you say to individuals who would kind of push back and say that may potentially be a very idealistic and utopian worldview? And I ask that question because my the main reason why I'm a little bit uneasy about supervised injection sites, and don't get me wrong, I think there's great efficacy for methadone, Suboxone, and medication-assisted treatment for substance use disorders in general. I'm totally in agreement there. But when it comes to supervised injection centers, I initially my thought was that this is a great idea, but when I started looking into it, especially when it was implemented in San Francisco in the Tenderloin district, one of the things that I found was that out of all the people that came and utilized drugs in the supervised injection centers, only 1% of individuals were rerouted to mental health services. So I kind of take that to mean that 99% of people who were utilizing those services didn't actually want or have a desire to get better, and perhaps that's it's a consequence of that program not being around long enough. Maybe there was some other issues with the design and how that program was implemented, but regardless, however whatever side of the fence you fall on that issue, the reality is that Tenderloin district, the supervised injection center, because of that kind of criticism, has closed down. So
Mm-hmm.
how do we get more people who are actually using drugs and who may potentially want or support supervised injection centers? How do we get more of those patients to actually pursue treatment at the end of utilizing those services? And
To
is
be
that even an
honest,
important thing, in your opinion?
I don't know the answer. I think like I'm not an addiction psychiatrist, so like I like the level of information that I have immediately available is somewhat limited in that regard. But on the flip side of that, like we've all like we were all just in residency. The easiest place to find psychiatrists is in residency programs when they're knee high to a grasshopper, as we say in the South. But I had an insane clinic schedule. I'm sure you have insane clinic schedules. So, like in regard to the issue in with the Tenderloin district, only 1% of them ended up getting any kind of psychiatric treatment. I don't necessarily know that it's because only 1% of them wanted psychiatric treatment or wanted the ancillary mental health and substance use services. Um, it could really be an issue of just straight up access. Let's face facts here. Most psychiatrists run cash only practices, and part of the reason we do it is because it's such a goddamn headache to deal with insurance companies who refuse to pay mental health workers at the same level of parity uh, that they pay physicians in literally every other specialty. So there's multiple issues of like resource allocation, policy goals of just availability, because like the need for mental health providers of all sorts, psychiatrists, psychologists, counselors, therapists, etc., is insanely high. And the pandemic only made it that much worse. Like I used to tell people, like don't um, pandemics tend to obviate the social inequities that are out there and then exacerbate them. It's a yes and situation. It's not an either or situation, you know? And so that's really, for me, that's really one of the shortcomings of what you described in terms of the situation in the Tenderloin district. The it was sort of pouring a drop of water on a forest fire.
Hmm. I think that's a really good analogy. Yeah, and I'll give my 2 cents kind of into this topic. I almost wonder if, like, full legalization of all drugs could actually be a technique that maybe could lead to a different outcome. I don't know. At least, I think dealing with the demand for drugs is so challenging, and on a philosophical level, how could we get there? I have some own ideas that I'll talk about later. But as for the supply, if we have illegal substances, there's always going to be crime organizations that try to fill that supply. If there's a demand for a product and it's illegal, some kind of crime is going to fill in. That's going to be there. So if you take that out, therefore at least the demand's going to be there. Do people want to get high? They want to get fucked up. At least if they can do so safely in some kind of safe way without the concern of overdose, therefore you do at least prevent some death, some harm. How we intervene with getting those individuals into treatment, I'm not sure. That's what kind of gets me so excited. Perhaps the way that we can really address the demand side for the drugs is something like psychedelics, is something like psilocybin, LSD, DMT. Is that maybe going to change the brain chemistry, the desire to get fucked up on a daily basis with these substances? I'm not sure. That's kind of what I think maybe my future career of psychiatry is going to get into, because that's something that I get stoked about. Can you really like shake a person in reality with these substances to radically change their desire for a behavior? So, it's been about 40 minutes. We've been really getting into some deep, tough topics. So I think we should
Yeah.
change to some more lighthearted ones. So Tola, I don't think you know this. So my mother was an art teacher for many, many years. And she's always kind of instilled in me the power of being creative, of using art as a modality, as a coping strategy. You touched upon how you enjoy photography. You've been on a podcast discussing photography and mental health. So, how do you try to teach your patients about using maybe photography or other artistic realms to improve their mental health?
So there's been one of the things I love about this job is that you can really show up as your whole self. If you're a psychiatrist, the things you're passionate about, I guarantee at least one of your patients is going to be passionate about. So, for example, I tell this story all the time because it's just so cool to me. I had this one patient that I was doing psychotherapy with, and he had horrendous nightmares to the point where he had gotten out of bed and concussed himself at least on one occasion. Um, and in the process of diving into psychotherapy, I learned that he really liked movies. And we had started talking about the source of his nightmares. And it had to do with a lot of family issues, cultural issues, because he was an Asian man. Um, and so we started trying to help him at least reduce his nightmares. And so we talked a lot about film, movies like Inception. Inception like paints a really great picture of what it's like to know that you're in a dream state, and in so doing, it paints a picture of lucid dreaming, right? And so we used Inception, and we used the Loki series on Disney Plus, where he's like hopping through multiverses and changing timelines and things like that. So we used those as a scaffolding to really illustrate the idea of lucid dreaming, and then teach him the basic principles of dream rehearsal therapy. And over the course of that, we were able to help him at least reduce the frequency of his nightmares. He still had them like once every few months, but it wasn't like a regular thing that was a part of his life anymore. He was able to get an improved night's sleep and all of that kind of stuff. There are a lot of interesting ways to go through creative outlets and use them to improve your mental health. The simple act of attempting uh, to do any sort of creative pursuit will do wonders for your mental health, not just in terms of like neuroplasticity, but also in terms of like helping you process complex emotions. And there's ample data about stuff like that. And so I highly encourage everybody to pick up at least one creative outlet, and especially if you're going to do it badly, right? Because I think that's one of the things that makes people shy away from trying to do anything creative, is that they want to be good right away. So, yeah.
Yeah, I couldn't agree more. And I don't necessarily bring up the idea of photography, but I can imagine a lot of my patients being like, "Well, yeah, no, I don't have a good camera. How could I practice photography?" And it's like, "Well, come on, like I'm filming this right now on my iPhone. All of us can at least embark in some measure of photography, right, to try to express how
Yeah.
we feel." And it makes me think a lot about, like, I mean, these days I know in inpatient psych wards we occasionally, it's not as frequently as I like, but have like an art therapist roll through, and individuals can color and all this shit. When I was in the inpatient psych ward myself, I was like, this is the dumbest thing I've ever done in my life. Like, why am I fucking coloring? I'm 22 years old. So I almost wonder, as our careers progress, 20, 40 years from now, I guess I'll still be practicing 40 years from now, maybe. Is an inpatient psych ward, are we ever going to allow our patients to have cameras? Is that something that is a violation of HIPAA, or is there a version of a camera that, like old school cameras, like those, like you have those little things you move to the right and you take a little disposable pictures? Like, you obviously can't take
Hmm.
those photos with you, but I wonder how we could incorporate that into uh, our practice, maybe in the inpatient setting. It's obviously a lot easier in the outpatient setting. Joon, I know you have a particular interest in photography. I'm curious, have you breached this subject with any of your patients?
Photography being allowed in the inpatient units, that
No, 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 no.
specifically?
Just I
No.
guess just
Okay,
having
just
a
about
conversation.
creativity.
Yeah, yeah.
Okay,
No,
because I was
let
like,
me
yeah,
just fucking
hey,
rant.
I heard you that.
You're
I heard
like,
that one, and I'm like,
all
ooh,
right,
man, I can't picture that happening anytime soon.
not yet.
But yeah, I think
Yeah.
this topic of creativity, right? I think it touches on a deeper sense of our humanity. I think at the end of the day, I mean, at least this is my personal experience with creative outlooks. I've dabbled in some street photography years ago, black and white street photography, and now like we're doing this
That's the
podcast.
best.
This is a creative outlet for us, right? And in a sense as well. And Tola, you also mentioned that like this idea of having to create a perfect product, and that's why people are afraid to be creative. That's actually something that I struggled with a lot, in starting this podcast. And Logan has been to be frank, a great mentor for me in overcoming some of that anxiety. That anxiety, like that voice in the back of your head that says, "Oh, if I,
Hmm.
put out this thing, if I let people see it, they're gonna think I'm dumb. They're gonna think I sound, not very eloquent, whatever it may be." Right there, you just have so much anxiety over it. But in reality, like people are vastly caught up in their own lives, especially like content and creative endeavors these days. Everything is so like moment to moment, and there's so much being created that yes, maybe you'll get some attention for like a split second, but the next day is just completely forgotten about from everybody's minds. Whether that's a good thing or a bad thing, I would also echo that sentiment and encourage other people to undertake creative endeavors, because there is so much benefit from it. And I mentioned earlier that creative outlets, especially when I talk to my patients about it, I kind of think about it on a deeper level. I think about it as kind of on the sense of what makes life worth living, right? Because
Mhm.
that's what mental health is to me, right? Of course, we can talk about depression and anxiety, but at the core of it, at least to me, it's a question about what makes life worth living. And I think there's something innate about human beings where we want to live we want to do things that's bigger than ourselves. We want to spend our time in ways that we can leave a mark on the world, right? And I think to a large degree, that's what creative endeavors are. When you take photographs, right? When we're creating digital content like this podcast, right? Before, after all three of us are long gone from this earth, this medium is going to continue to carry on. This medium is going to be available for anybody that's willing to take the time and take a glance at it. It's going to tell people that, hey, at a point in time, Tola, Logan, Joon, these are people that existed. These are people that had feelings, that had desires, and that had goals in life. And I think that's what the main point of this conversation is today, right? We're having these challenging conversations, and at the end of it, we're trying to figure out how we can best help the people that we're seeing on a day-to-day basis. So in that sense, I think it's a reminder that life is bigger than ourselves, and it's proof, it's something tangible that you can see and point to and say that I've existed, that I've mattered, and that I've made an
Exactly.
impact. So that's kind of how I think about creative endeavors. That was a very long monologue, and I'm going to pass off the mic to somebody else.
No, like I completely agree with you. My philosophy, because I do a lot of like portrait work, especially, and I also shoot like weddings on the side and stuff. But like fundamentally, the philosophical angle in terms of photography is really thinking about two things, especially in like portrait photography or like client facing work. You have two goals. One is documentation, because you're saying that this person, these people, this moment, this event, it mattered. And so the simple act of taking a photograph in any context is documenting what that moment was like, at least a simulacrum of it, because a photograph isn't reality in any sense, but in a larger sense, especially in like portrait work, there's also an aspirational element to it, because you're trying to show off the best version of that moment a lot of times. So like in the two goals don't necessarily always align, because like you could be documenting a shitty moment. There's no way to create the best version of taking a photograph of a natural disaster, right? And so like those two goals aren't always aligned. um, but most of the time, especially when people want to document like the happy joyous occasions in their lives, there's there's documentation, and then there's aspiration. And I sort of, and like people have asked how like that dives into like my how that jives with my psychiatric practice. And it's really sort of the same way. Like in your psychiatric assessment, your first half is really about documentation, and then like your assessment and plan is really about aspiration. You're really taking all of that information that you have documented and trying to figure out how to use it to help that person move into a headspace or a life space that's more meaningful for them, that they're aspiring to.
I like it, man. I like it. Well, hey, Tola, we've taken 53 minutes of your time, so we're already over your budget here. We really appreciate you coming on the show. I look forward to when you come back, because you'll definitely have another invitation whenever you want it. So,
I
Tola,
appreciate it,
any
man.
any last words that you want to spew into the internet sphere, all 200,000 of our listeners?
So I always say, take care of yourselves and each other. Like we all exist in community, and especially because we talked a lot about like addiction and stuff like that. They always say the opposite of addiction is connection, and I fundamentally believe that to be true. So take care of yourselves and each other. That's the only way we'll make it out this world, right?
Right.
I
I
love
think
that. Thank you so much, Tola. We appreciate you coming on, and you've certainly taught me so much during this episode, and I really appreciate you sharing your expertise with us.
Thank y'all for having me.
all right. Cheers.